Bojana Yankovic-Weatherly, and today I have the pleasure of talking to an integrative cardiologist, Dr. Vivian Kominos. We're going to be talking about women's cardiovascular health and integrative approaches that are evidence-based of how to reduce our risk of cardiovascular disease. One of the reasons that we decided to have this discussion is that many women are not aware that cardiovascular disease poses the biggest threat to their health. So we're going to be diving into how can women's symptoms sometimes differ compared to symptoms that men experience when they're having a heart attack. We're also going to be talking about how women's outcome can be worse when they're having a cardiovascular event compared to men. And there are many factors involved in this. Then we're going to be talking about some of the lifestyle, nutrition, supplemental, and pharmaceutical supports that we can use as primary prevention, meaning to prevent cardiovascular disease in somebody who hasn't already had a heart attack or another cardiovascular event. We're going to be talking about the evidence on nutrition and provide what is the current state of our knowledge and understanding on this, with the understanding that there have been many, many papers written on this. We're also going to be talking about some of the key lifestyle areas that should be examined and that can significantly impact cardiovascular outcomes. And lastly, we're going to touch on the supplemental supports that have some evidence behind their use, as well as medications. We're going to talk a little bit about some of the diagnostics, some of the imaging that can be done in order to enhance our risk assessment and determine whether somebody might be higher risk than we originally thought. Of course, there is so much more to unpack here and to share here, and this is really just kind of scratching the surface, but I really hope that this provides you with a good overview of some of the things that you may want to discuss with your physician in terms of what would be applicable to you and what are some of the things that you can do in order to support your health and reduce your risk of cardiovascular disease. I hope you enjoy this. Hi, everyone. Today I have the pleasure of interviewing Dr. Vivian Kominos, and we're going to be talking about cardiovascular health in women with a specific focus on integrative cardiovascular health. To tell you a little bit about Dr. Kominos first, she's a cardiologist and a fellow of the American College of Cardiology. She's a nationally recognized clinician and educator in integrative cardiology and is a graduate of St. Louis University School of Medicine. She completed her internal medicine residency and cardiology fellowship at Robert Wood Johnson University Hospital in her home state of New Jersey. She's board certified in both integrative medicine and in cardiology. She has practiced cardiology for over 35 years. That's very impressive, and has concentrated on integrative medicine and integrative cardiology for the past 15 years. She recently retired from private practice and now concentrates on teaching and volunteering. She provides cardiology care to uninsured at Parker Family Health Center in Red Bank, New Jersey. And she's also clinical assistant professor of medicine at the Andrew Weil Center of Integrative Medicine, which is how she and I met. She has completed her integrative medicine fellowship there in 2007. Dr. Kominos is also a founding member of the American Board of Integrative Medicine, where she served as vice chair and remained an active board member until 2020. And besides being a mentor for the fellowship training in integrative medicine, she's also intimately involved in the fellowship educational curricula, authoring modules on topics ranging from cardiovascular health and disease to nutrition, mind-body medicine, which, as we'll learn, is also very important for cardiovascular health, and obesity. She's a speaker and educator to her peers, medical students, and residents, as well as nurses, allied health professionals, and the community. And she enjoys volunteering at the Parker Family Center, as we mentioned, and also loves running, kayaking, cooking, and spending time with family and friends, and her 3-year-old granddaughter. Well, I love it. You have such a wealth of experience, Vivian, and thank you so much for joining us today.
Thank you for having me, Bojana. It's always a pleasure seeing you.
So we're going to dive right in. Let's talk a little bit about some statistics about women and heart disease. Oftentimes when we hear about heart disease, and even I can say this, with my back to my medical training and medical school and residency training, we often focus on men, right? We are taught that, men have a high risk of heart disease. And unfortunately, over time, this has really compromised women that are potentially presenting with some cardiovascular symptoms. So tell us a little bit about the statistics.
Yeah, that's a great point. And it's true that more men than women die from cardiovascular disease. But what we want to keep in mind is that cardiovascular disease is the leading cause of death in women, killing 35% of women. So if you're a woman, you have a 1 out of 3 chance of dying from cardiovascular disease. And what's the most common cardiovascular disease that kills people? It's coronary artery disease, right? It's blockages in the blood vessels of the heart. Unfortunately, something that you did mention is very true, that we were taught that it's a man's disease, right? What were we taught? We were taught that one of the major arteries in the heart, the left anterior descending artery, is called the widowmaker. And at a talk that I was at last night, I heard that term again. I hate that term. I think we have to stop using it. What does it say? It says that widowmaker, first of all, it tells the poor guy that's on the cath table having a heart attack, hey, guy, you almost died. That's hexing the person. And it says it's a man's disease, and it really, really isn't. And I think that one of the things that I found very disturbing recently is that when we did surveys of women, there was a survey conducted in 2009 and another one in 2019 to ask women, what is your major health threat? And what do you think women said in general?
Probably breast cancer, I would think, because there's so much publicity on that. Right.
More women than men. More women said breast cancer than said heart disease. And what really concerned me is that between 2009 and 2019, fewer women knew in 2019 that heart disease is their chief, health threat. And that I found disturbing, especially Hispanic and non-Hispanic Black women really didn't have as much knowledge as they had in 2009, and especially young women. And when does heart disease start? It doesn't start when you're 50 or 60. It starts in your teens and your 20s, right? Mm-hmm. That's why we have to prevent it from in utero, right? We have to prevent it from the time we're conceived. Yeah. So I found that a bit disturbing. And I think it's the lack of awareness among women and sometimes lack of awareness among physicians that is leading to certain disparities that we're seeing between men and women, because women tend to have more complications and don't do as well as men when they have heart disease.
Mm-hmm. Yeah, exactly. Yeah. And, the other thing that's really interesting as well is that women can often present differently, right? So I'm wondering if you can walk us through, right? We've all certainly had experiences, whether it's in training or even in primary care. Sometimes people present with symptoms and you're like, you're having an MI. I need to get you to the cath lab right away. But certainly you've had these experiences, many times. How can women's presentation of cardiovascular event, of a heart attack, differ from men's? And why might they sometimes be dismissed as this is anxiety, for example?
Yeah. Unfortunately, a lot of women who are having a threatened heart attack or a heart attack wait to go to the emergency room because they think it's stress or anxiety. So that's a very interesting question, because up until recently, I was using the terms women have atypical chest pain, meaning it's not the classic, fist across the chest, like a heavy weight radiating to the left shoulder. So men might more frequently have these typical symptoms. But what's interesting, in a recent study that looked at men and women that presented to the hospital with heart attacks, about 87% of women had chest pain and 89% of men had chest pain. So women with acute heart attacks, acute coronary syndromes, do present with chest pain. The thing is, women more often than men will also have additional symptoms. And they might have more shortness of breath, more fatigue, more palpitations, more nausea or back pain or jaw pain. And I think if you're going into the emergency room and you already think you may not be having a heart attack, and you're telling the emergency room physician that, hey, I'm having all these symptoms, maybe it clouds the picture a little bit, and they may not treat you right away as if you're having a heart attack. And it's really, sad when you look at the statistics. When women call 911, they're having chest pain, they're less likely to get an intravenous, they're less likely to get an EKG, they're less likely to be transported to the hospital right away. In the hospital, this disparity continues. They're less likely to be referred for an angiogram. And if they have a heart attack and they're in the hospital and they get discharged, they're less likely to be given evidence-proven pharmacotherapy, drugs that they should be on. They're less often prescribed statins and aspirin. They're less often referred for cardiac rehab. So it's true that symptoms might vary a little bit, and these are being blamed as part of the reason why we're seeing a difference between outcomes in men and women. But I think it goes deeper than that.
Mm-hmm. And it sounds like along the diagnostic and therapeutic pathways, there are all these gaps and all these disparities that you're mentioning. It's not just because they're being misdiagnosed, or there are actually elements of treatments that may differ, or where there may be biases. I'm curious, since you mentioned the diagnostic component and some of the presentation might potentially cloud the symptoms, do we know if there's any difference in terms of, some of the metrics that we may have readily available in the ER, some of the data, such as EKG or troponins? I mean, do we expect the same changes in men and women just because of the anatomy, or the same troponin elevation, or might there be some gender-related differences there?
Yeah, I'm not sure about the level of troponins. I don't recall seeing a study about that. I mean, EKGs are going to be abnormal in men and women. Maybe during stress testing, EKGs in women vary from men. Regular stress tests may not be as sensitive, but in the emergency room with our high sensitivity troponins, you're going to catch if someone is having a threatened heart attack or a heart attack. Yeah. Mm-hmm. What's very interesting is many, many years ago, when men and women went to the cardiac catheterization lab, they found out that a lot more women who went to have dye injected into their arteries, a coronary angiogram, had normal looking arteries than men, even though these women were having chest pain symptoms indicative of heart disease. And even though they had abnormal imaging, like abnormal nuclear stress tests or abnormal CAT scans that showed that they probably had some sort of problem with blood flow in their heart. And what they found is that more women than men didn't really have these clear-cut, significant obstructive blockages. They had more what we call microvascular disease. And microvascular disease, very small blood vessels that you may not see on cardiac catheterization when you inject dye. We don't see all the little tiny microvasculature. And women more often than men have this issue. So often, and I've been to blame for this before we knew what was going on with women, I would do the angiogram myself and I would tell the woman, your chest pain is nothing. It's not nothing. It's not probably not coming from your heart. When in reality, we learned later, remember, I've been doing this 35 years, so a lot has changed. We learned later from the WISE study, the Women Ischemia Syndrome Evaluation study, that looked at these specific women, that these women had a higher risk, even though they may not have had these clear-cut blockages or major blockage in the arteries. They may have had what we call non-obstructive disease or just irregularities. These women had a much higher chance of dying from a heart attack or premature death, or just having a cardiovascular death. So The pathophysiology is a little different in women than in men. We do know that women do get heart disease at a later age in general than men because our estrogen protects us.
Mm-hmm. Yes. And this is another thing that I'm curious about because as you know, there's some controversy on this topic, but right, we know that up until menopause, estrogen is protective, right? And so there's also some evidence if women enter menopause earlier on, that might actually increase their risk of cardiovascular conditions. However, once we start treating with HRT, and again, there may be some age-related and potentially dosing-related effects, that overall there may be some increased risk of that. And we know that, again, with certain exogenous hormone use, meaning with taking hormones that are not made in your body, that might increase the risk of blood clotting as well, right? Which is part of that process. And so it's always interesting to me, does something intrinsically change in how the endothelium, right, which is the lining of our blood vessels, how it responds to these hormones, where the body just suddenly says, no, now my risk is up if this is introduced to me? What happens? I mean, how much do we know about what happens here, really?
Yeah, there's been like 180 degree and another 180 degree turn in my experience. So when I started my career in 1989 in private practice, at that time, we were prescribing hormone replacement therapy to everybody. It didn't matter if you were like 70 or 50, if you were postmenopausal, we thought this is going to be good. Mm-hmm. It turned out that it really wasn't good for certain women, for women that already had established cardiovascular disease, and for women who were quite a few years past menopause. Mm-hmm. And what we're finding now is that if you replace with bioidentical hormones, so if you use like a transdermal patch, for instance, there's no risk for increased thromboembolic disease usually.
Right, it's lower than oral. Exactly, it's lower than if we're treating with oral estrogen. Mm-hmm.
Right. So, and I don't know how many women still are taking oral hormone replacement. Maybe they're out there. That's not something that I would recommend. But if you replace the estrogen within 10 years after menopause, it looks like your risk for cardiovascular disease goes down. Mm-hmm. So we do know that it's protected. Mm-hmm. Yeah. So, but again, this turned around where initially we were using it to everybody. Then we stopped completely to a point where I wasn't given it when it could have benefited me. And now we've turned around again, but with certain caveats. So women would come to me for clearance for hormone replacement therapy. I'm not the one that gave it. Somebody that was, where this was in their field would give it, but I was the one that would do a cardiovascular assessment. Mm-hmm. Currently, cardiology guidelines do not recommend hormone replacement for cardiovascular disease prevention or for the treatment of dyslipidemia, mm-hmm. although we are learning that, and these are going to change, obviously the guidelines always change every few years, that it could be protective when given at the right time.
And my understanding is that this is very similar to the Menopause Society guidelines as well. There's an acknowledgement that there are some studies that earlier on, as menopause starts and in those first 10 years under the age of 60, that there may be some benefits, but it's not recommended to be prescribed for that reason, right? And so,
for prevention.
But it's so interesting that something in the physiology changes, right? Like what our response is to those hormones, that it's protective up until a certain point, and then it doesn't seem to be, or it seems to in fact maybe increase the risk after that certain threshold. But as you said, these guidelines are ever evolving.
They're ever evolving, and we're learning more and more about the structure of the lining of the blood vessel and the glycocalyx, and just what happens to the lining of the blood vessel as we change, or if we have certain risks for cardiovascular disease. And it's just fascinating what we're learning, and hopefully by the time my granddaughter is in her 30s and 40s, we know how to prevent heart disease completely.
Yeah, you're right, because it's the number one cause of mortality for men and
Mm-hmm.
women. And
Mm-hmm.
so before we dive into, talking more about prevention, because I know we want to cover a little bit about prevention, a little bit about lab work, and then also some pharmacotherapy, which is a lot, but at least we'll give an overview. There's so much there, but I wanted to just kind of go back to basic science because, we've mentioned the endothelium, we've mentioned the lining of the blood vessels. People often ask me in my practice, we go over lipid panels, we go over advanced lipid panels, and there's a lot of information out there, right, about different risk factors that may lead to cardiovascular disease. As you've acknowledged, cardiovascular disease can take decades to form, right? So when we think about it, we're not really, or generally when I talk to my patients about it, I say, I'm not just worried about your tenure risk, which is kind of like the standard of care risk assessment when we think about do we want to treat aggressively or not with medications. I'm really worried about your lifetime risk and what we can start doing now because it's cumulative. Can you walk us through a little bit, kind of how does the actual cardiovascular disease start, and what are the different, there's this whole inflammatory understanding that we have. Maybe walk us through that a little bit to set the stage when we talk about prevention and labs and medications.
Sure. I mean, I don't know that I can give a PhD level dissertation on it. But what do we know? We know that the lining of the arteries becomes damaged. And how does it become damaged? It becomes damaged because LDL that is circulating becomes inflamed or oxidized, and it enters into the cell wall. The lining of the arteries is like one layer thick. This enters into the cell wall, which causes an inflammatory cascade. You get these cells that form that are called foam cells, and our bodies are wonderful healing machines. What happens if they see something that's inflamed? Other cells go to it, macrophages, other cells, lymphocytes, and they cause this, they try to heal it. And in healing it, they actually can form the start of a plaque, and that's basically how it starts. So what are the things that are going to cause that? Oh, so many things that we're surrounded by, especially us, that our grandparents weren't surrounded by. Toxins, environmental toxins. I mean, I saw this paper a few months ago that showed that in lining of the arteries in our neck, in the carotid arteries, there's nanoplastics. There's actual plastic in our arteries. Of course, it's going to cause an inflammatory reaction and start all kinds of chronic diseases. Smoking is going to oxidize LDL, and lack of physical activity, bad, unrestful sleep, stress, all of these, an imbalance of our autonomic nervous system, unhealthy food. I mean,
insulin resistance, right?
Insulin, yes, definitely.
Blood sugars. Mm-hmm.
It's all these, classic risk factors that we know about, and the ones we are not talking enough about, or what? The environmental toxins, the emotional stressors, trauma. I mean, these are all also very, very important.
Mm-hmm. Yeah, absolutely. And it's like the way that we perceive and cope with stress and how we channel that has such a tremendous impact on our body. And we know that there's a correlation with inflammatory markers. We know that inflammatory markers also correlate with our risk of cardiovascular disease. But then there's also this direct effect of, just to touch on this a little bit, right? But even if you look at our, sympathetic nervous system and parasympathetic nervous system, which is our vagus nerve is part of this, we often I treat a lot of people with IBS, with irritable bowel syndrome, right? And we know that this vagus nerve tone is down in people with gut issues, with chronic gut health problems and irritable bowel syndrome. We also know that the vagus nerve dictates our heart rate. It's part of the input to our heart that dictates our heart rate and our heart rate variability, which is another metric that people often monitor with their wearables that's a predictor of health and disease. And so I agree with you in that we kind of, we maybe acknowledge it now more than we did before, but oftentimes we kind of just accept it and brush it off, and it's like, oh well, it's just one of those things. But it really does have a big impact. Now let's talk a little bit about prevention, and kind of try to do it as much justice as we can in the time that we have. But I really wanted to touch on a few different areas, right? The big one being diet, because people often ask, okay, well, what should I eat? And there are so many options out there, right? And so many philosophies and books on this and papers, right? That can often be confusing or misleading because we know the sort of limitations also of some of the nutrition research and food logs and all of that stuff. But from what we have available, I'm curious to hear, you as a cardiologist, how do you typically counsel people? And I know our philosophies align, but I'd love to kind of hear, based on some of the major studies, your clinical experience, what are some of the things that you tell people that are actionable steps that we know are going to reduce their risk of cardiovascular disease?
Yeah, sure. So, well, first of all, I think I want to reiterate lifestyle is the most important way to prevent disease, right? Which includes nutrition and exercise and stress reduction and, sleep and no tobacco and community, everything, right? So let's talk about diet. I'm of Greek descent. I was the first one in my family born here. I grew up speaking Greek before I spoke English. So I grew up with the Mediterranean diet with my yaya cooking everything. So I am definitely a proponent of the Mediterranean diet. What's interesting about diet studies is most of them are what we call correlational. In other words, we follow large cohorts, numbers of people for many years, and we see, well, what are they generally eating? And this could be based on food frequency questionnaires, which may not be perfect. And we follow them for 5, 10, 20 years. Do they die from heart attack? Do they die from stroke? Do they get dementia? So, nutrition research is somewhat limited and isn't really following the gold standard of our research, which is randomized controlled trials. Mediterranean diet, though, is pretty interesting. We do have some randomized controlled trials that were very large that show that it is beneficial in both primary and secondary prevention of cardiovascular disease, specifically coronary heart disease. There's a Lyon diet heart study that was done on 600 survivors of acute MI. And what it did is it randomized them to either a Mediterranean type diet or a low-fat American Heart Association diet. And for those of you that know what the Mediterranean diet means, it's not a diet per se, but a way of eating in the countries that surround the Mediterranean. So let's say in some places like Greece, you might eat more fish. In other places, you might eat more vegetables and maybe more pasta or cheese or but it's a sort of a way of eating in the people that in the countries that surround the Mediterranean. So anyway, in the Mediterranean diet is not low fat, and these guys that were survivors of MI had a higher fat diet. They had like 50 to 60% lower incidence of a recurrent heart disease event. So that's telling us, well, maybe low fat is not the way to go. Then there's the PREDIMED study that took over 7,000 people that were at high risk for cardiovascular disease, not MI survivors. And so they also subject. It was. That's right. That's right. This was more of a primary prevention, and followed them for 5 years. And what they found was that the Mediterranean diet that was supplemented with either extra virgin olive oil or nuts did better than the low-fat diet. So again, we have that evidence from randomized trials. But there's another one, the DASH diet, dietary approaches to stop hypertension. That's probably the gold standard, because this took hundreds of people who had hypertension up to systolics of up to 160, did not start did not start medication on them, and they could only eat what was given to them from the test kitchen. So this was definitely like a controlled trial. Mm-hmm. And it randomized them to 3 different diets: Mediterranean, or a DASH diet that was lower in fat and higher in non-fat dairy than the Mediterranean diet, and the typical standard American diet, so horrible food, right? Mm-hmm. And what they found was that the DASH diet was the best diet in lowering blood pressure, followed by the Mediterranean diet, and not the standard American diet. Didn't really do too much. So we have a few randomized controlled trials. Both of these diets, DASH and Mediterranean, are what? They're very high in plants, right? In vegetables, in fruit, in legumes, in whole grains, and they're low in saturated fat from meat. So they might include fish, they might include meat a couple times a month, but they're really low in saturated fat, so that the American Heart Association now recommends maybe 7% or so. Your total calories less than 7% should be from saturated fat. So I do like the Mediterranean diet or a DASH diet, but I also want to look at the person's culture, right? Because am I going to tell somebody that is from Mexico, where a lot of my patients are from, well, you got to go on a diet like what my yaya cooked? No. Mm-hmm. So what we do is, what's nice about the Mediterranean diet, when you look it up, that you can actually adjust that for different parts of the world, so that you're concentrating on more plant food, less salt, mm-hmm. less added sugar, hardly any added sugar, and low in high glycemic load carbohydrates, that white stuff that gets digested very quickly, that gives you insulin resistance, that adds to visceral adiposity, that starts the whole inflammatory cascade, or continues and causes all kinds of chronic disease with the obesity epidemic that we're seeing. So there's other diets that have proof. Obviously, there's very low fat, which is put out by the Ornish Heart Disease Reversal Program. We've had evidence that works. But what's interesting is it doesn't work for everyone. So, if one of my patients wants to go on a low-fat vegan diet, absolutely, I work with them. I make sure they see a nutritionist, make sure that they're getting all the vitamins and minerals that they may be missing on a vegan diet. If somebody wants to be an omnivore and eat everything, I work with them also. And I eat some red meat. I might eat it maybe twice a month when I feel like I want it. It's not exactly anything I crave, but I feel like I need it. So, I tell people, you want to feel good when you're eating, but you want to eat good food. You want to basically eat real food. So we can, I don't like to give a diet per se to my patients. The way that I practice, I would have them fill out a 3-day food diary, and then we would look at it and we would say, okay, what's good, what's bad, what is it that you can't do without? And we would go from there, and we would improve it that way.
Yeah, and I completely agree with you on that approach. I think that we're human after all, right? And so there's an element of so much of how our culture shapes us. I mean, you with your Greek family, and myself with my Serbian family, and people from that there's an element of food that's so much tied to our culture, to our loved ones, to like food is love and energy, and there's so many connections there. And then also thinking about what's practical, what's accessible, what's conducive to one's lifestyle, right? There are so many things there that I think it's really important to emphasize. There's no one size fits all. And the other piece too, and because I did go back and I re-reviewed the PrediMed study, because I know it's one of the, largest studies that specifically looks at this, use of diet as a primary prevention tool for cardiovascular disease. And, when they looked at these people who were eating the Mediterranean diet and extra virgin olive oil versus Mediterranean and nuts, compared to people who were on the low-fat diet, the difference in fat is only about 4% on average, right? The extra virgin olive oil and nut people with Mediterranean were 41% of fat by the end of the trial. And then the reduced fat were 37%. So it's not even, it's probably, all the other things that they're also consuming, and how are we sequencing our food? What else are we eating? Is it packed with lots and lots of fiber and polyphenols and all of these other things, right?
Right. You mentioned polyphenols. And what's interesting is I think that one of the real great functional foods of the Mediterranean diet is the extra virgin olive oil, because it contains all these incredible polyphenols, these plant chemicals that are anti-inflammatory and antioxidant. And they're like anti-carcinogenic, they're anti-thrombotic, they're anti-atherogenic. I mean, they're just amazing. I think that, I tell people, make sure you're getting a couple tablespoons of olive oil, extra virgin olive oil in your diet every day.
Yeah. So, yeah, absolutely.
And you're right. And you're also right about saying, what is the company that your food keeps, right? Mm-hmm. I mean, this was not really a low fat diet that the controls were on in the Predimed, right? It was 37% low fat. It wasn't a 15% fat diet. It wasn't really low fat. So it's sort of misnomer to call it really compared to low fat.
Low fat, right. And I'm curious to hear what your thoughts are on eggs. The Mediterranean diet allows some eggs, and there's a lot of controversy in the literature too, in terms of there's, research showing that one egg a day or more in people predisposed to diabetes is going to increase that risk. There are some studies showing that cholesterol that you consume does not actually make a difference in your blood cholesterol. Other studies showing that it does. What do you make of all of this?
Yeah, this changes every month, right? There's data that changes every month. I think it's safe to say that if you are not a cholesterol super absorber, because there are certain people that carry certain gene variants that will absorb cholesterol. It's a minor part of the population. The majority of the people, their lipids aren't really going to be affected by eating eggs. So for most people, I'll say having a few eggs a week is fine. I mean, do I think you should have like a couple eggs a day? No. But for the most people, it's not really a problem. So, but I also saw the literature on, the relationship between eggs and diabetes. And I often wonder, what is it that they were eating with the eggs and how do they prepare them? Exactly. And you don't always find that in the studies. And that's why that's why nutrition research is so difficult to interpret. Let's take another example, if I may. Let's take saturated fat, right? I'm not a big proponent. I don't like saturated fat. I think saturated fat is associated with cardiovascular disease and inflammation. So, but there are people that, publish papers that, saturated fat is okay. Well, if you look at, one of the studies like the PURE study, and it looked at different nations across the world, and what it found was that the higher the saturated fat intake, the less disease they had, or they had better outcomes. But what were they comparing saturated fat to? Mm-hmm. It's possible that in countries that were poor, they weren't able to afford good food, right? And what are they eating? They're eating food that's high glycemic load, processed carbohydrates, basically. So you have to look to see if you replace saturated fat with sugar, what's going to look better? Mm-hmm. Saturated fat's going to look better. But if you replace saturated fat with olive oil or plant protein or plants or fiber, that's going to look better. Mm-hmm. So there's no study that tells us that, hey, I'm going to increase my saturated fat to prevent a heart attack. There's absolutely no study that has ever shown that.
And what's so interesting too, right? We have different studies of, randomized controlled trials, which is obviously extremely difficult, if not impossible, to do with nutrition. But then we have these epidemiological and observational studies as well. And blue zones often come up when we talk about mortality and diet and whatnot. And so I really got into the blue zones during one period of time, and I'm still really kind of curious and fascinated by them, even though I know there are a lot of difficulties in terms of getting records and really truly knowing the age of the population, that kind of thing. But I had the opportunity to visit a blue zone in Sardinia about 6 or 7 years ago. And I interviewed this doctor in Sardinia in the blue zone. And then I interviewed one of his patients who was 99 and a half at the time through a translator, of course. And it's so interesting. So they had this room in this small village of Arzana in Sardinia that had beautiful photos of these people kind of acknowledging them and celebrating them, these centenarians in this town. Mm-hmm. And one of the things that this particular blue zone is known for is that it was the higher proportion of men that lived to be over 100, which again is kind of unusual because women statistically live longer than men. And what was interesting, I was asking this, because these were all his patients. I was asking him about what were they eating? What was this person's life like? And it was just one of those, it was so beautiful because he really knew his patients so intimately. And it was like that kind of thing. And he was telling me about somebody who was eating animal fat all the time. And this person, and you hear about blue zones and beans, and not that they weren't eating beans and all the other things, but they also actually do eat animal fat and goat cheese and sheep cheese and all these different products. But there are so many things there that we can't yet, maybe with AI one day we'll be able to better understand, the impact of the environment and how they were moving every day up and down the hills and the eating this, he called it the 0 kilometer diet, which I really loved because it really kind of illustrates the idea of eating what we're genetically meant to be eating, where we evolved, and in the seasons that we're meant to be eating these foods. And somehow this was probably protective. I mean, again, there are so many factors there, and there are genetic advantages that this population has. But I think it's so interesting. Like you said, it really just illustrates there's no one size fits all. And it's all relative.
You're right.
It's relative to what else are you comparing that to?
You're right. And I think one of the things with the blue zones, if you look at all the blue zones, they have incredible communities and community support. I went to Ikaria, which is another an island that's also in the blue zone. And I was there during one of the saints festivals. Greeks have saint festivals every other day. And, what they do is they go to the mountain, they get the goat, and we eat the goat. So I'm eating goat meat, which is but these are goats that live out in this beautiful blue zone themselves. So if the goat eats well or the meat eats well, you're going to eat better. And that's why
get some omega-3s too.
Yeah. Sure. When my patients want to eat, and when I want to eat red meat, I just tell them, make sure it's grass fed, make sure everything you're getting is organic, make sure it's clean. I don't eat, the stuff. If you see the way meat is processed and the way they raise cattle, you are not going to want to eat it ever again.
Yeah.
The usual way. Yeah.
Yeah, definitely. Yeah. Oh, I love that. I've actually been curious about going to Ikaria. I'll have to ask you more about that.
Oh, it's gorgeous. It's fantastic.
Yeah. Oh, I love that. Okay. So I know that we have a few minutes left before we end. I'd love to kind of hear some of your pearls when it comes to medications and then some of the supplements that you might consider in people for cardiovascular disease prevention. And we can focus on prevention here because, obviously pharmacotherapy medications are used for prevention and after somebody has had events, but maybe for the purpose of this, we can really just kind of talk about prevention.
Yeah. So, we have so much data going back decades and decades on what drugs work for prevention, and the drugs were aimed at reducing, especially statins, reducing LDL. And what I tell my patients is that, we're not just reducing a number, right? What we want to do is we want to reduce your risk for having a heart attack or stroke or cognitive dysfunction or cancer or death or, all the chronic diseases. And we know that statins work. And we know that statins work as well in women as in men. I'm still hearing things like, oh, well, statins don't really work in women. Well, what happened is initial studies didn't include that many women, but with later studies, and we've had these studies now for years that have as many women as men, or enough women, we know that they're just as beneficial in women as they are in men. And usually patients that would come to me to see me in my practice would come because they didn't want to go on statins.
Right.
And if I sat there and explained, the benefits and the risks, they usually walked out with the statin prescription. Because if somebody needs it, if they're high risk, meaning their baseline LDL cholesterol is greater than 190, or they've already had heart disease, or they're at intermediate risk where they have like a 10-year chance of 7.5% or more, or they have other risk factors like diabetes. We don't just look at the traditional risk factors. I often would do calcium scores, which are very ultra fast CAT scans. If there's any calcium in your artery, especially if you're younger, you have heart disease. You're at high risk. So statins will help prevent that. And there are people who can't take statins. They react badly to them. 7% supposedly have statin-associated muscle symptoms, but that's in a population that's studied in trials. When you look at a community population, they're a little different. So it's a little bit higher, closer probably to 10 to 12%, or maybe even up to 15%, it's estimated. So if you have trouble with statins, the good news is there's a lot of other drugs out there that work. There's Zetia, which was the next one that came out, which prevents cholesterol absorption through the gut. There's PCSK9 inhibitors, which are amazing. These are shots every other week that you can give yourself, and they have tremendous decrease, more so than Zetia, in the reduction of heart attack and stroke. So, there's a lot out there. There's bempedoic acid, and then there's inclisiran. Inclisiran is the only one that we don't have outcomes data on yet. But bempedoic acid, PCSK9 inhibitors, Zetia, statins, all of these are very useful, and they all reduce incidence of heart attack and stroke if you're high risk. And 1 out of 3 women will have a heart disease event. So we're all high risk. Mm-hmm. That's how I feel. But obviously we prevent with lifestyle before we use medications if it's primary prevention. Now, some of my patients are definitely against prevention. Not against prevention, against drugs. So for them, we may use certain supplements. And there's a few supplements that do reduce LDL cholesterol. The one that has the most evidence is radius rice. Why does it have the most evidence? It actually contains a natural statin in it, monocolin K. And I'll tell people that. I have to tell them, hey, this is a statin. It's a natural statin, but it's in a small amount, and it's surrounded by other plant chemicals that also may work. So we actually see a reduction in LDL cholesterol that's much more than what we would expect to see with the small amount of natural statin that's in it. There were some studies that showed that in people with heart disease, it does reduce heart attack and recurrent heart attacks. So that's good. There's citrus bergamot. If you like Earl Grey tea, it has that nice flavor in it. That's from a citrus plant that grows in Italy, and it's delicious. And citrus bergamot also decreases LDL cholesterol. There's berberine that I use. Now, don't just start taking these, obviously, because I view supplements the same way I use drugs. I like to see if they're effective. I like to make sure they don't have any adverse side effects, and I want to make sure they don't interact with something you're eating or a drug that you're taking. So I'll use some supplements. But even more important than that, I try to get people to move. I think exercise is one of the most important, and physical activity. We weren't made to be still. We just weren't. We were made to move. So, we do know that exercise improves cholesterol. It improves the lining of the endothelium. It improves brain-derived neurotrophic hormones so that you don't get You don't get cognitive dysfunction as much as, you would get if you were just standing still. Exercise, probably one of the most important things you could ever do. Sleeping, getting restful sleep. And I'm a meditator. I'm a transcendental meditation practitioner, and I love it. I think that meditation does decrease cholesterol. We know that. One of the first studies I read about how stress can increase cholesterol was in medical students, and they measure their cholesterol. And this was done decades and decades ago. And they measure their cholesterol before a test and after a test. Went up by about 20% before, after the test, or when they were anticipating being tested. So we know that stress increases cholesterol. So how can we reduce it? You don't want to just use a pill. You don't want to just use one method. This is what integrative medicine is about. It's a multimodal approach that looks at everything. It looks at lifestyle, looks at supplements, it looks at community, it looks at environment and toxins. And the other thing about integrative medicine is that it looks at the patient as a partner and an expert in their healing process, right? Mm-hmm. So I think one of the important things that you do and other people like you do is you spend time with the patient. Mm-hmm. And, what I want to really insist on, that women and men, but especially women, because sometimes we're not listened to, make sure you found someone that'll spend time with you, that will really listen to you, that will have compassionate communication with you, and that will look at your goals and what you want to do, because that's probably one of the most important aspects of integrative medicine, is how we treat the person as an individual, right?
I agree with you so much. And I think that, people more and more are recognizing that they want to take control over their health. They want to feel empowered. They're not coming to us to get advice and be kind of a passive participant in the process. They really want to get to the root of what's going on. They want to understand what are, like you said, different modalities that could help them. They understand that maybe medications are a solution, or maybe there are other things that could be tried, or maybe all of these things together. And so I'm seeing definitely more and more people kind of coming forward, wanting to optimize, wanting to be proactive, and really kind of see how they can take charge of their health and reduce their risks. And I think it's very interesting, like the trends that we're seeing now. And acknowledging the fact that, again, medicine is evolving, right? So we do the best we can with the evidence that we have available now, and with how the patient is presenting, and with their values, their goals, as you said. And then the plan may evolve over time as we gain more knowledge, as we better understand. I like what you said about, measuring the results. And this is what I do as well. If either, let's say, medications are not indicated, or maybe the patient doesn't want medications, but they're open to some supplemental supports, I'll say, okay, well, here are the ones that have been studied where we have some evidence where they can potentially reduce your cholesterol. We don't have as much data about the outcomes, like you said, as we do, Red D-Strides is kind of the one supplement where we do, but let's track, let's see how you respond to this. And, some of these, like berberine, can also potentially help with some insulin resistance as well, which is often a problem at the same time. So it's about monitoring. It's about, being responsive to what we are seeing clinically, not just on labs, while labs are important to follow, but also in the person. And I always tell my patients, labs are a factor in what recommendations I'm going to make and how I'm going to track progress. But I'm not treating the labs, I'm treating you. So this is where I seek that partnership and that participation to really make decisions together.
Yeah. And thank you for the work you do, Bojana. I think that it's wonderful. We need more people like you out there. And that's why I love teaching the fellows that are coming out of the program. I think it's a fantastic program. If anybody's out there who's a physician who wants to get trained on how to be a better physician, and also for self-care. I think that's how I started. I started it because heart disease hit my home. And I felt like I was, not a great cardiologist at that time. And certainly I was just practicing in a conventional way. And the fellowship taught me, medicine again, and made me a better practitioner. So, and I'm grateful to it. Yeah.
Yeah, I agree with you completely. And by the way, for anyone listening, the fellowship did not ask us to endorse them.
Oh, no, not at all.
We're just speaking from I agree with you completely. And now that I'm a mentor in the fellowship as well, it just reinforces what a great group of physicians. And, I know we all go out there with these intentions to heal and help people. And then the system, unfortunately, puts some roadblocks to that in a way, and boundaries to that. And then as you said, learning integrative medicine and understanding how much is really in our power, in our control, can really, really change the outlook, can really change the outcome. And I think that's so important too, because it's also about the process of how are we in our relationship with our condition. What does this mean to us? I interviewed one of our fellows actually. For one of these episodes, she's an integrative surgeon in the program. And she leads with a question, what does this condition mean to you? Why do you think you have this? And there's so much, storytelling and meaning making in medicine as well that again, I didn't learn so much about, until we did the fellowship training. Well, thank you so much, Vivian. Of course, there's always so much more to discuss, but I think this was a really helpful overview for people, and I'm so thankful for your time.
And I'm grateful to you for having me, and just keep doing all the good work you're doing.
Thank you, and likewise. All information in this video, including but not limited to the video itself, the audio, text, graphics, images, and other material contained in this video, is strictly for informational purposes only. The content is not intended to serve as or be a substitute for professional medical, pediatric, or psychiatric advice, nor is it designed to suggest any specific diagnoses or treatment. Please always seek medical advice from your physician or qualified healthcare provider regarding any medical conditions, questions, or treatment, particularly before making any changes to your healthcare regimen, medications, or lifestyle habits. Never disregard professional medical advice or delay seeking help from a healthcare provider due to something you have heard, seen, or read in this video or audio. Reliance on any information in this video or audio specifically applied to your own case is solely at your own risk.